Hi, everybody. Thanks for joining us. We're just waiting for people to be admitted to our webinar today. Just seeing all of you guys. We miss seeing you all in person, and hopefully someday again we will be reunited with snacks and new bodies. All right. Okay, so pass it on to Dr. Rugo.
Wonderful. And thanks, everybody, and welcome to the Bay Area Breast Cancer Forum. And you just saw Melody Gawliu, who is the glue of our forum and organizes this and coordinates our Zoom license and everything about this. So welcome. And we have some fabulous speakers tonight to talk about San Antonio. I suspect that we'll have to do another San Antonio review. We have March 29th currently on the books for our next forum, but we love to hear from you. So if you have ideas of things you want to hear about or comments back to us about how you felt the forum went, we'd love to hear it. And as you can see in the bottom of your screen, you have a Q&A button. Please put your questions in there because it allows us to actually answer them even by typing as we go along. And if you have any trouble, of course, you can chat into Melody, but overall, it's better if you use the Q&A button, I think. Today we have myself, Hope Rugo, from the Breast Oncology Program, and I'm joined by Michelle Melisko, breast medical oncologist, and then two people who aren't quite here yet from the breast medical oncology side, Joe Chen and Saya Jacob. So Joe Chen, I think, is well known by many, one of our breast medical oncologists, and Saya Jacob, who's a senior breast oncology fellow. Great. And then we're really thrilled to have Lisa Singer with us. Lisa is one of our stellar breast oncology radiation oncologists. And actually trained here, went to Boston, and we were really fortunate to be able to hire her back on our faculty. So we're going to hear, weren't able to get a surgeon who was free this evening. And there were some interesting local therapy topics, but we'll talk about those later. And this year, San Antonio was just full of new information and new studies, which I think have a lot of clinical impact, but we're of course interested to hear from you about your questions. So we're going to start with Michelle. We have like far-reaching areas to talk about, both what kinds of therapies to get in different situations, novel agents, new approaches to radiation that work and some that don't, and then I think even ways for prevention and survivorship. So we'll talk about a lot of these different areas. So we're going to start with Michelle, who's going to talk about a study that was very cool, I think, called The Right Choice. And this study was designed by our colleagues in a number of countries, including Egypt, Jordan, Taiwan, and a number of other countries, funded by a pharmaceutical company, but really asked the question about if you have metastatic incurable cancer in your young woman, is it better, and it's hormone receptor positive, is it better to start with hormone therapy or chemo? Michelle, what is the answer to that? Tell us how that study went.
Great. So I'm going to go ahead and share my slides, and I'm hoping that people can see the slide here from the beginning. I'm going to try to get it to see my, hopefully people can see the screen here.
Yes, it looks great. You could put it on presentation mode, maybe.
Yeah, that's what I'm trying to do to get it to go from the beginning. Okay, so is it in presentation mode
Perfect.
now? Mm-hmm. Okay, so as Dr. Rugo said, for patients with newly diagnosed or newly diagnosed metastatic breast cancer, particularly I'd say those patients that have de novo metastatic disease where, they come in and they have never received any treatment for any breast cancer. They find out they have distant metastasis. It's often kind of surprising to those patients when we tell them that their therapy is going to consist of hormonal therapy in some cases, in many cases. And patients, often have the idea that, well, my cancer is stage 4, it's spread to my liver, it's in my bones, why don't I need to do a more aggressive path of treatment? And, we in the United States tend to use a set of guidelines called those from the National Comprehensive Cancer Network, as well as guidelines from ASCO and other organizations that suggest that taking an approach that really focuses on quality of life and starts with a hormone therapy-based approach for estrogen receptor positive breast cancer is the best path. However, there are those patients that show up with more aggressive disease where we become very worried that perhaps their cancer is growing so fast in their liver or other organs that we might be better off starting with chemotherapy. So that's really what this study was trying to investigate. And so on the left side of the screen, you can see that this was a trial that included women who were premenopausal or perimenopausal, had hormone receptor positive breast cancer, had no prior treatment for advanced breast cancer. They had to have measurable disease, which means that on a scan that we could actually, put a ruler up to a lesion in the liver or the lungs or a lymph node and be able to actually measure it. They also had to have this, what was defined as aggressive disease, meaning that they had visceral metastasis, and visceral means something like in the organs like the lungs or the liver. The bone is not considered a visceral organ, and they had to be symptomatic from those. They also had to have, they could also meet the criteria by having a definition of having rapid disease progression or impending visceral compromise. So the appearance that perhaps their liver might stop working. So these are the kind of patients that in the past we might lean towards giving them chemotherapy. And this question was, could we actually give patients a hormone therapy-based treatment? So as you can see here, patients were randomized to get a hormone therapy-based treatment. It could be one of 2 aromatase inhibitors plus goserelin, which is ovarian function suppression. And then they gave that in combination with ribociclib. The other name for that is Kisqali, which is a CDK4/6 inhibitor. Patients were randomized to either this regimen or the regimen of the investigator's choice of chemotherapy, which could consist of a number of combination chemotherapy regimens that you can see here: docetaxel plus capecitabine, otherwise known as Xeloda, paclitaxel plus gemcitabine, or capecitabine plus vinorelbine. And they had a number of endpoints that they were looking at, including how long it took for the patients to progress, ultimately looking at response rates and overall survival, as well as quality of life. And so I'm not going to spend a lot of time on this slide, except to say that the number of patients in the trial was about a little over 200. And, this was a young population. Again, the goal was to look at premenopausal women. And I mentioned that word de novo metastatic breast cancer, meaning that whose breast cancer showed up, they had never had cancer in the breast before. So this was a high percentage of patients. Almost 2/3 of the patients were showing up with de novo metastatic disease. And it was a mixture because this was conducted in a number of diverse countries. There was a high percentage of Asian patients. And then lastly, because treatment is based on being hormone receptor positive, they looked at the percentage of patients where their tumors were over 50% hormone receptor positive. And, sometimes another question that patients will ask me in the audience, if I tell them that we were looking at their biopsy and their cancer is only 10% estrogen receptor positive, we still actually consider those patients to have the potential to respond to hormone therapy. But what I want to point out here, population was a group of women where over 50% of the cells that were biopsied in their tumor were hormone receptor positive. And to cut to the chase, this is the data on the progression or the progression-free survival for the combination chemotherapy. The median was 12 months versus the combination of an endocrine therapy plus ribociclib. The median progression-free survival was 24 months. So that's pretty impressive. Most patients would have the idea that chemotherapy would be the much more aggressive and therefore more effective approach. But in fact, that isn't what turned out to be the case.
Can you define, Michelle, PFS?
Yeah, progression-free survival, PFS stands.
No, but I mean what it means.
Okay, so that means that at the time point that patients are along the time of the trial are getting scans as they go along, and at a given time point they have to be alive and their scans have to show no progression. Chime in, Hope, if you think there's a better layman's way of describing it.
Cancer isn't growing.
Yeah. Okay. Yep. They're basically, and then the thing though that's interesting about something like progression-free survival, and there's a number of different terms that come up in clinical trials. They are all a little bit nuanced. That's unfortunate that if someone dies of another cause, that actually counts against the arm, because even if they aren't progression-free, they haven't survived. So it's kind of tricky in terms of looking at this clinical trial data. But basically, this is the period of time that their cancer was stable on this treatment. And the median, of course, means that 50% of the patients progressed before this time point and 50% progressed after. And as you can see here, there's curves out here where even out as far as 36 months or 3 years, there's a good percentage of patients that are still stable that haven't progressed on this combination of ribociclib and endocrine therapy. And so then another factor, we often think that chemotherapy has higher response rates, but in this trial, they looked at something called the overall response rate, and it was very similar between the two arms, and then the clinical benefit rate. And so clinical benefit rate is the combination of patients that actually had a response, as well as the percentage of patients that remained stable for a period of time on the study. And in most studies, that clinical benefit rate is looking at a period of stability of 4 to 6 months. And then the last thing I'm going to show about this slide, which may be the most interesting, is the adverse events. And so looking at the total adverse events, both with, looking at all grade, which means did patients have any side effects? Well, as expected, it's about 100% in both arms. Then they looked, though, at treatment-related serious adverse events. So bad things that happened to patients that they thought could be attributed to the arm. It was higher in the chemotherapy arm. And then the type of treatment-related adverse events that led to the patient stopping the chemotherapy, that was also higher in the chemotherapy arm. So overall, that lends us to believe that the endocrine therapy approach was better tolerated. But, one thing that's quite interesting is people think of chemotherapy as being, quite, immunosuppressive, myelosuppressive, meaning lowering their blood counts, reducing, increasing the chance of infection. And what is quite notable here is that actually the percentage of patients that had neutropenia or a low neutrophil count, that's one subset of the white blood cells, was actually quite a bit higher in the endocrine therapy arm. And I think that surprises a lot of patients that even though ribociclib, palbociclib, abemaciclib, these are, biological therapies, targeted therapies, the blood count suppression that can go along with these drugs can be quite common. Some of the other things that we saw, there was almost an equal amount of anemia seen between the endocrine therapy approach and the combination chemotherapy approach. As you would expect, there was more nausea, more vomiting with chemotherapy, more diarrhea, more alopecia, so hair loss and more fatigue. And then palmar plantar erythrodysesthesia, it's a big long word, hand-foot syndrome, which is something we see with capecitabine chemotherapy. So all in all, there was, a tendency that there were, more GI side effects with chemotherapy as expected, but fatigue, also significantly greater with chemotherapy. So in summary, we have, really further evidence that patients, even with visceral metastasis, liver mets, lung mets, where we're concerned about their liver function, that it is safe and actually more effective to put them on an endocrine therapy approach.
Yeah, I mean, this is such a great study and so cool that they were able to do it in the countries that enrolled the patients. Taiwan, they do a lot of studies, and the person who presented is from Taiwan, but the other countries really don't participate as much in trials. Some in Turkey, but it was Turkey, Jordan, Egypt, and another country, which I'm not remembering, but I think that they were really long time biased that young women who had visceral disease or, involvement of lungs or liver should get chemo first and, cause a lot of toxicity and also promoted endocrine resistance. And I think, what Michelle showed, which is so interesting, that you just can't stay on this they gave combination chemo. We give single agent sequential therapy in this setting, which follows our guidelines, but they believe that more is better. So you give this combination chemo, it's so toxic, you can't keep on it, so people stopped, as Michelle nicely showed. So one of the questions that came up, Michelle, is would you attribute this was done in pre and perimenopausal women? Is the same thing true in postmenopausal women?
I would expect to say that it's even more so in postmenopausal women because, premenopausal women are going to have, fewer, comorbidities. So they're going to be more likely to be able to tolerate the side effects of chemotherapy. Endocrine therapy is generally, more effective in older women. Those older women tend to have a higher percentage of cancers that are more strongly hormone receptor positive. So absolutely, I think that this study, if this was, duplicated in the postmenopausal population, we would see exactly the same thing or even more in favor of endocrine therapy.
Yeah, and somebody else asked about, I totally agree with you that what about early stage disease, but we won't get into that. Suffice it to say that in early stage disease, it's really complicated, influenced by age, menopausal status, and gene expression tests, as well as amount of disease.
So I'm going to go ahead and stop sharing my screen now so we can move on to the next.
And so now we're going to go on. Lisa's going to talk about, although we lost her, there she is. Lisa Singer, our radiation oncologist, is going to talk about, are you there, Lisa?
Yeah, I'm just having some technical difficulties. 1 second.
Okay, we can go on to another one instead.
There was also a question about why an aromatase inhibitor for premenopausal and not tamoxifen. The answer to that is that there is a safety issue with tamoxifen and ribociclib. I'm actually interested in hearing your thoughts about this, Hope, is that, in the Monarch-E study, which we're going to talk about later, they did allow patients to receive tamoxifen with abemaciclib. And there's also, just to answer the question, with ribociclib, we don't generally give tamoxifen because there's a concern about safety. But when we get to the Monarch-E study, I think it'd be interesting to talk about, Hope, how you decide for your patients. If a patient is having a really hard time tolerating an aromatase inhibitor, do you feel reasonably safe knowing there's an increased risk of thromboembolic events with tamoxifen and abemaciclib that we can?
So the answer to that is no. And if I do people on it, I usually put them on a low dose anticoagulation because I have just seen enough of it. And in the metastatic setting more, but still the risks were much higher if you were taking tamoxifen. The answer in the metastatic setting is an interesting one. I mean, all the randomized trials that looked at AIs versus tamoxifen showed that AI was superior to tamoxifen. And so if you're going to try and compare chemotherapy to an endocrine therapy, you want the next best, the best thing. And we know that adding ribociclib to aromatase inhibitor improved survival. And there's a black box warning about giving ribociclib with tamoxifen because of the risk of QT prolongation or changing the EKG, although I have to say it hasn't resulted in any major problems. It's a theoretical risk we just don't want to take. So we know AI is better than TAM, and we know there's risks with TAM and ribociclib. So I think that's the reason why in this situation. And we try, in the early stage setting from people who have very high risk disease, I can't imagine using tamoxifen because we also know that ovarian function suppression improves outcome in patients with high risk disease. So it is, stopping the ovaries, I think is part of that. So let's see. And one of the questions was about young women who are premenopausal with metastatic disease to note only. So you could type a response too if you want,
Sure,
Michelle.
I'm happy to type that in there.
Okay, great, good. And we'll go ahead and Lisa, I think who's back on now, will talk about, the POLAR study, one of the radiation studies, looking at a way to try and understand which women really need radiation therapy and is this ready for prime time?
Thanks so much, everyone, for having me. Can you see the slides okay?
Yep.
Looks great.
Okay, great. I wanted to talk about this topic because a lot of times we think of lumpectomy and radiation as a package treatment for patients with early stage breast cancer. And for the most part, it is a package treatment. But the question will always come up, is it possible not to have radiation? Well, we know we can deliver radiation very safely nowadays, but we never want to put people through treatments that aren't going to help them. And that's because all treatments do have risks. And so there was a really exciting study presented from Sweden, where the authors went back and looked at one of the older randomized studies that was done to test the benefit of radiation. And so decades ago, there were multiple randomized studies from around the world where women with early stage breast cancer were randomly assigned to get radiation or not after a lumpectomy. And what we found from those studies is that radiation significantly reduced the risk of the cancer coming back in the breast area by 2/3 overall. And so these authors actually went back and looked at the tissue from one of those studies that was done in Sweden. And they specifically looked at the tissue from patients who were randomly assigned not to get radiation. And that's because now that decades have passed, we unfortunately know which of those patients did have a recurrence and which didn't. And they wanted to find out if there was something about the biology of those cancers that tracked with recurrence. And there were over 1,000 women in that particular study. To test if there was something tracking with recurrence, they had a subset of about just under 300 patients, and they specifically looked at patients who didn't get any radiation and actually who didn't get any chemotherapy or hormone therapy either. And they were able to develop a signature. And so this is a signature of the underlying biology in that cancer. And they were specifically looking at gene expression. And so all the cells have recipes for making different proteins, and different cells in the body will express those differently. And they were trying to understand how the cells of those breast cancers were expressing the genes. And once they came up with that signature, they then tested it in another group of patients from that same trial done in Sweden to see if their signature was predictive. And then they went ahead and also tested it in a couple other trials. One was from Canada and one was from Scotland. And what was really interesting, I just wanted to show that most of the patients actually were in their 60s, so very few patients less than 39. And you can see there was a spread in terms of grade of the tumors here. And again, they built this on a small number of patients, so just under 300. But what they found was that that signature that they had developed actually did track with local recurrence. Local recurrence is the risk of breast cancer coming back in the breast area. So these patients who had a low signature and didn't have radiation, that's the blue line, their recurrence was actually similar to patients who got the radiation and just turned out to also have a low signature. Remember, when these studies were done, we didn't know what the signatures were. Those women were participating in the trials for a different reason, to find out if radiation was beneficial overall. The authors also found that when the signature was high and the patients didn't get radiation, their risk of the cancer coming back was actually really high. And the reason this is so interesting is because we actually don't have a good signature right now of breast cancer biology to know which patients could omit radiation. There are a couple studies done in women over 65, and there's an ongoing study right now called the DEBRA trial, which is looking at early stage breast cancers with oncotype score that's lower, randomly assigning those patients to get radiation or not. So we'll know a little bit soon. But I think this was a very intriguing study because there is promise for this polar signature. One thing I do want to emphasize is this isn't ready for prime time. So this was a retrospective study, and you may ask your doctor if you could get the polar signature, but unfortunately, this wasn't a randomized study, so we definitely want to bring the best to our patients, but I think it's very intriguing and the field could really move forward in the future.
That was really great and very interesting. So I have a question for you. Is this only for hormone receptor positive disease? What about HER2 positive and triple negative?
Really good question. It was mostly luminal A and B.
So these are all, just so that people understand what that means. So the majority of patients had hormone receptor positive, HER2 negative breast cancer, and the majority of patients were postmenopausal. And this makes a really big difference in terms of looking at long-term outcome. The biology of cancer is different in older women. And by far, the majority of patients here had the slowest growing hormone receptor positive disease. So I think that that's important when we think about it. You can see that when you look under the bottom on the left there, endocrine therapy in almost all of the patients. So, and endocrine therapy also reduces local recurrence, right?
Yeah, and I think it's important to remember that the signature was specifically developed in women who didn't get hormone therapy, and that might actually be a great treatment option for a lot of patients. So I think this is just the beginning of that investigation, and we really need more studies to be done.
So Lisa, I'm going to ask you another question. There's been a lot of questions about which patients can get really short course radiation versus long course, because, you know, we're trying to think about who needs radiation at all. We have some idea in older women, but what about overall? Who can get 5 days of radiation?
Really great question. We have a lot of new radiation options for patients. So one of those is a 5-day partial breast treatment. And that means we're just treating the area of the surgery with a small margin or extra area just to make sure that we're getting everything safely. And patients with early stage breast cancer, small tumors, estrogen positive, lower grade, other favorable features may actually be eligible for that option. That's 5 days partial breast. We also have a 5-day whole breast option, which comes from Europe. That study only has 5 years of follow-up, so it is important to discuss with your doctor if that's a good option for you, but that's also an option for a lot of our patients. So we've really gone from 5-6 weeks for everyone to shorter, more tailored courses.
And who would be thinking about that 5-day whole breast?
Patients with early stage breast cancer where we're not treating the lymph nodes primarily.
I see. And so does it matter if it's HER2 positive or triple negative or et cetera?
There were other subtypes on the study, but they were underrepresented, as were patients who received neoadjuvant chemo. And then with the only 5 years of follow-up, I think it's something we need to really consider for each case if it's the right option.
Great, that's really helpful. Oh, that was really interesting. So maybe though you can look in the chat, somebody asked, how does a patient find out what their signature is to see if radiation would be beneficial? So why don't you go ahead and answer that in the chat.
I don't believe this is commercially available yet.
You can, if you.
Oh,
you
I can write it.
write the
Okay,
answer,
sorry.
Yeah, so that works out well. Michelle, do you have time if somebody else does one more?
Sure. Yeah.
Okay, great. So
There was
we
also
have now.
someone had raised their hand, but I'm not sure if that is.
No, they put the question in, I think.
Okay,
So,
got it.
nobody can talk on this one because we have too many people, but except for us. So we have Syed Jacob on, our senior fellow, and Joe Chen, I think well known to everybody on the forum, our colleague in breast medical oncology, and they have some really interesting areas to talk about as well. Maybe we'll start with Joe, do you want to briefly talk about, well, maybe you want to go a little bit later just because I know you were busy in clinic, but Syed, do you want to talk about the positive trial briefly?
Yeah, absolutely. Let me share my slides. And let's get it in presenter mode. All right, so this is the positive trial, and this trial was really to look at the safety of pregnancy for young women who are breast cancer survivors and really want to become pregnant. And so the background here is that, of course, there are many young women, unfortunately, who develop breast cancer and go on to surgery. And many of these women have estrogen receptor, progesterone receptor positive tumors, meaning that really they're looking at 5 to 10 years of endocrine therapy even after their surgery. And this becomes a problem for a lot of these women who maybe have limited amount of time in which they can become pregnant. And so being on these treatments can really even further limit the time in which they're fertile and can complete their family planning goals. So one kind of unanswered question around this issue is, what is the outcome for patients who stop endocrine therapy in order to become pregnant? And do they really have worse outcomes compared to patients who don't stop their endocrine therapy? So this was a trial. It was an international trial that looked prospectively, which means that they followed patients over time after an intervention was made. And really the purpose of the trial was to address, is it safe from a recurrence perspective for patients to briefly interrupt their endocrine therapy and try to get pregnant? And this trial was really geared towards the hormone positive disease patients who would be undergoing endocrine therapy. Anyone who was premenopausal, wanted to become pregnant, was under 42 years of age, and had at least completed 18 months of endocrine therapy, but no more than 30 months of endocrine therapy could join. And so the authors really just wanted to make sure that there was some minimum amount of endocrine therapy that had already been given. Whether or not a patient received chemotherapy or fertility preservation did not affect their ability to enroll. And the other big thing is they couldn't have had any signs that they already had a recurrence when they enrolled. So the way it worked, patients would stop their endocrine therapy and enroll in the trial within 1 month of stopping. And then after that, they had up to 2 years during which time they could attempt pregnancy, conceive, deliver, and breastfeed. And this included about a 3-month washout period, meaning 3 months where they're no longer on the drug and the drug has time to leave the body. Patients who were not able to get pregnant within a year were allowed to seek fertility counseling and assessments and treatments. And then after those 2 years had completed and after a patient had become pregnant and delivered, it was strongly recommended that they restart their endocrine therapy. And the goal was really to complete the full duration that was planned. So if a patient completed a year and a half and then stopped the treatment to get pregnant, the idea would be that when she restarted, she would complete whatever time was remaining to finish either 5 or 10 years. The trial was really looking at a couple of different endpoints to measure the success or safety. The main one was the breast cancer-free interval. So that's looking at the amount of time patients would go before some of them would develop a recurrence, either in that breast or in the other breast. They also looked at several other things like pregnancy outcomes, how healthy were the children, breastfeeding, how many people got back onto their endocrine therapy, and also distant recurrence-free intervals, the amount of time that, or the number of patients that would develop a recurrence outside of the breast. And the reason that's important is that the recurrences outside of the breast are such that we can no longer really cure it. So those are the really life-limiting and dangerous recurrences. The study was planned to enroll about 500 women, and there were 3 different stopping points at which the study coordinators would assess the safety. So for example, if early on in the trial, many patients were getting recurrence, and that would be a signal that this is not a safe intervention and that we should stop the study. And then the recurrence rates in this trial were compared to another trial called the SABCS trial that had been done several years ago and enrolled about 1,500 patients. And all the patients in that trial were on endocrine therapy continuously for 5 to 10 years. So they were really trying to compare what's the rate for these patients who paused their endocrine therapy and what's the rate for patients who didn't pause. So the trial ended up enrolling about over 500 people across multiple different centers, continents, countries. So really was a diverse population. Most of the patients were between the age range of 35 to 39, about 43%. And most of them had never had a birth prior to this. So about 75% of patients did not have any births or children. Another quick thing just to note from this slide is the majority of patients had either stage 1 or stage 2 disease. There weren't really that many patients with stage 3 disease, only about 6%. Most of the patients who enrolled in the study were on a SERM, or in other words, typically that would mean tamoxifen, and were also on ovarian function suppression. So this is the main outcome of the trial. So the dark brown line represents the patients on this study, and the dotted black line represents the comparison from the SOFT and TEXT trial. On the left side, it shows the breast cancer-free interval. So that, again, is looking at recurrences in the breast. And on the right side, it shows the distant recurrence-free interval. So that's recurrences outside of the breast. And I really want you to focus on the 36 line. And if you go up, you'll see 2 percentages of 9.2% for the patients who were in the prior study and 8.9% of patients who were in this trial. So that represents the percent of patients that had had a recurrence by 3 years. And you can see there that that number is pretty similar. There wasn't a huge difference in those numbers. Similarly, with the distant recurrence-free interval, the numbers again at 3 years are pretty similar, 5.8 and 4.5%. So the takeaway here is that these patients that had paused their endocrine therapy still had similar rates of recurrence compared to patients who hadn't. This is a quick slide just to look at some subgroups of patients that had higher rates of recurrence. Patients who had more nodes that were positive, bigger tumor sizes, higher grade tumors, meaning that on the pathology, they looked like more aggressive tumors. And then this is a little information about what happened with the pregnancies. And so 74% of women who stopped endocrine therapy in this trial actually did get pregnant, and 64% of them had a live birth. The offspring tended to be either average or high birth rate. It was a minority of patients with low birth rate, and very few birth defects. Most babies born were normal and healthy. And then this is last thing I'll talk about is just the number of patients that went back on treatment. And it was about 76% of patients went back on endocrine therapy successfully. Of the ones that didn't, most of them were delaying still to try to get pregnant. So I think that kind of summarizes things. Let me see if I can stop
That's great.
sharing.
You're doing great. That's great, Sai, really helpful. So let me ask Joe a question. So Joe, do you take this as pretty definitive? Is this long enough follow-up? Most of these patients had hormone receptor positive disease. What are your sort of take on it and concerns?
Yeah, no, that's a really good question. So 3-year follow-up really isn't long enough in this population for ER positive, HER2 negative tumors. I think I commend the investigators here because this is a really, really tough question to try and answer. And the fact that they conducted this study, finished the study, and were able to generate these results is a huge victory, but it's not definitive. This is really short follow-up. And I think also we have to look at the numbers and really think, is the comparator the appropriate comparator, right? Were the patients in the positive study similar to the patients in the soft text study? So I think there are still many questions, but I think it's a big win for the field. This is a really, really relevant question for so many of our patients, and it's just great to have some data.
I think in one other question that comes up, and Michelle, maybe you might want to comment on this, is there a patient where you wouldn't recommend this? What kind of situation where you'd be nervous about holding endocrine therapy at 2 years?
Yeah, I mean, if you go back, I want to make show the slides, but clearly, if you have a patient that has, for example, the kind of patient I would think about is someone who did neoadjuvant chemotherapy, had a very high residual burden of disease at the time. So we have evidence that they really didn't respond very well to their neoadjuvant chemotherapy, and maybe had more than 3 or more positive nodes. I mean, just the higher risk patients, I feel like I'm anxious about those patients stopping. Although one could argue that, those patients, if they're going to recur, they would recur early, and maybe they would have already recurred by the time they decided to stop at 2 to 3 years. I think it has to be a very individual discussion about it. And, the way that I approach this with my patients is that, we have to, I do, and Joe has studied this before, we try to give a patient sort of an understanding, an estimate of what is their overall risk of recurrence and what is that risk in that window of time that they might be taking a break. And it's fascinating to me. I think this is the mind, people wanting to, hear what they want to hear, or us perhaps trying to be more overly optimistic when we first meet patients. But I have patients that have come to me and said, I remember you saying that my risk of recurrence was 4%. And I was like, well, no, if we, your risk of recurrence, we could get it down to that if you could take 10 years of hormone therapy, and we could do this and we could do that. That doesn't reflect where you are right now. So I think the high risk patients in the soft trial, there was clearly huge benefit of staying on hormone therapy, and the aggressive hormone therapy of ovarian suppression plus AI in women under 35. That's, the women under 35, I try to, convince them, especially since so many of those patients have eggs harvested, they should stick it out and stay on hormone therapy for a little longer.
Yeah, I think that's a really good point. And, I think now with the advent of Verzenio or abemaciclib, the CDK4/6 inhibitor for patients with higher risk disease, also, it sort of delays time a little bit as well. And there are certainly situations where the risk is so high to stopping that, you have to wait a while. So harvesting eggs beforehand that you mentioned is such an important thing to consider, so that you have a backup, in that way you can have babies later, and you can also use surrogates if it's required. So all of this is really important. I think, the days when people could just say, oh, you have cancer, forget about the babies and just go with the treatment next week. Hopefully those are over, although they're not over everywhere. We just really want to be thinking about these, making sure we keep options open for patients.
Yeah, and I think it's important to, look at the numbers too, right? While it is similar to the soft text trial, but I think the point is at 3 years, they're seeing about 9% recurrence and 5% distant recurrence. And, that's not insignificant. The issue is that you don't know what you're comparing that to. And whether or not, if there was no break, if those numbers would be similar because you're comparing different populations. But if you just look at the actual recurrence rate, you have to, decide, is that meaningful or is that significant for you and this patient?
That's a really good point, I think. And, obviously it's contributed to by risk in the beginning and things we don't understand, but there may be ways for us to differentiate out who's at higher risk in the first 5 years versus, year 5 to 20. And then maybe that makes a difference. And if you took a break and continued with endocrine therapy, if your risk was later, would it be safer?
Yeah. I mean, it might be like 10% at 3 years is not low, right? So, but why is that? It probably, could just be the patient population, but, a lot of factors there that aren't clear.
I think some of that was local recurrence too. Right, that wasn't distant only.
Well, distant was 4 to 5%.
Yeah.
So that's, that's still at 3 years for ER positive disease is, worthy.
Right. In young women, absolutely agree. So cautiously optimistic, and great that they did the study, and we'll look for longer follow-up, which is wonderful. I know that Michelle has to leave a little bit early, so we might have her do her second presentation now. Which you were going to talk about contralateral breast cancer, I think, in patients who have genetic mutations.
Yes, so I'll go ahead and start sharing my screen again. And so now go to the slideshow mode, hopefully. Doesn't seem to want to go to the slideshow mode.
I use the bottom thing.
There we go. Yep. Okay, there we go. Okay.
Yeah.
So this, I'll go through this one very quickly by to summarize that as we are doing more and more genetic testing and expanding the number and types of patients that we're testing at the diagnosis of breast cancer, I would say overall it's been really a dramatic increase in the number of patients that we are identifying as having mutations, particularly in genes that we would call these intermediate penetrance genes like ATM, CHEK2, or PALB2. Now, most of the people in the audience are probably familiar with BRCA1 and BRCA2, which confers a very high lifetime risk of developing breast cancer. But now we're discovering these other genes that are also associated with increased risk. And this study was asking the question around the risk of developing a contralateral breast cancer, particularly in these mutations where their lifetime risk of breast cancer is high, but not as high as those with BRCA. And so just I'll skip that for the sake of time, and we'll go through, why is this important? If a patient is diagnosed with a unilateral breast cancer and they're trying to make a decision about surgery, it would be important to know. In fact, up until recently, we haven't really been able to provide those patients with a good estimate of what is their lifetime risk or long-term risk of developing a contralateral breast cancer. PV stands for pathogenic variants. So that means, these variants in these genes that increase the risk of developing breast cancer. And so, this data could inform our surveillance. So patients might be getting more MRIs. They might actually choose to have a prophylactic contralateral mastectomy. And we might also, increase, really change their risk management in general. So the study that we're looking at is called the carrier study. And there were two parts of the carrier study. There was one part that was looking at actually the development of breast cancer overall, not really looking at the contralateral risk, but what they did was they took a population-based case control study. So they found 32,000 women that had breast cancer. They matched them with 32,000 women that didn't have breast cancer. And they looked at their relative risk of developing the breast cancer based on if they had a gene mutation. And so you can see here what this means is that someone who is a BRCA1 mutation carrier in this cohort had 7.6 times the risk of developing a breast cancer as someone who was not a carrier of the BRCA1 mutation. The BRCA2 mutation carried a 5 times risk of developing breast cancer, PALB2 almost 4 times, ATM almost 2 times, and CHEK2 2 times. So this is developing any breast cancer in either breast. But what this study was looking at in terms of contralateral breast cancer was looking at a population of 15,000 patients that were in these prospective studies in the United States. And they were women that had been diagnosed with a breast cancer who kept their other breast and for whom they had 1 year of follow-up. and women who had DCIS at the initial diagnosis were excluded. And they had to have testing for those 5 genes in question: BRCA1, BRCA2, ATM, CHEK2, and PALB2. And they were looking at the time to developing a contralateral breast cancer between carriers of each of these genes versus non-carriers. And I'll skip that for the sake of time. This was a slightly older population, so 62 years old. I mean, not old in any way, but older than a lot of our PALB2 and BRCA mutation carriers are diagnosed in their 30s and 40s. Predominantly white, but there was a fair representation of Black patients. Majority were postmenopausal, 73%. Again, majority of these patients that had breast cancer were estrogen receptor positive. About 80% was ductal histology, and about 50% had used endocrine therapy at their first breast cancer diagnosis. And so what they found, the median follow-up time was 11 years. And what they found was actually quite surprising to me. That the percentage, so this is the total number of patients who were non-carriers, and in this population of women, 15,000 with breast cancer, this is the percentage of patients that carried each of these genes. So it was actually quite lower than I expected. We would have maybe thought that we would have a higher percentage of patients with genetic mutations, because in the past we've thought that perhaps as high as maybe 10% of breast cancers were attributable to a genetic mutation, whereas here it looks like it's only about 5% attributable to these mutations. And what they found based on the gene mutation is if you were a BRCA1 mutation carrier as compared to someone who had no genetic mutation, you had a 23% chance of developing a contralateral breast cancer out to, the median follow-up was 11 years, but you can see here, there were some patients that were followed out even longer. If you had a BRCA2 mutation, your risk was 17%. So that's, both of those are quite high. And I think that really does drive, the recommendation that if one's a BRCA1 or BRCA2 mutation carrier has been diagnosed with a unilateral breast cancer, they often make the decision to go ahead and have bilateral mastectomies. However, if you have an ATM mutation, this is one where we really had very little data on, there does not appear to be a significantly increased risk of developing a contralateral breast cancer. And with CHEK2, it's increased, doubling of risk, but it's not nearly as high as you'd see with BRCA1 or BRCA2. So for these two groups, one questions, does a woman who has one of these mutations really need to go through a bilateral mastectomy to prevent contralateral breast cancers? PALB2 is kind of an interesting story, because if you look at PALB2 patients overall, they have an increased risk of about 7.9% of developing a contralateral breast cancer. So similar to what we saw with the CHEK2 mutation carriers. However, if a PALB2, if their initial breast cancer was ER negative, then their risk of developing a contralateral breast cancer is almost 20%. And so that would suggest that perhaps those patients that have a PALB2 mutation have an ER positive breast cancer, and then they take hormonal therapy for that ER positive breast cancer, it may reduce their chances of developing a contralateral breast cancer. But if it's an ER negative breast cancer that they have, they probably would benefit from a contralateral mastectomy similar to those patients with BRCA1 and BRCA2. So I thought this data was fascinating. I think that it really does provide a lot of useful information for our surgeons and for our patients. And I'll stop and see if Hope has any questions there.
I think this is it is really fascinating. Small population, but that's what happens all the time. And I think that's it's, when you get to these mutations, you're always going to see small numbers, and Fergus Couch has been working on this forever. I think it's really helpful. And fits of course into my bias that ER negative disease, if you get ER negative disease, your risks are higher overall. And of course, you're not taking hormone therapy, so you don't have any way of reducing risk.
Yeah, I just think it's interesting because literally in the last month, I've had a patient with an ATM mutation opt to have bilateral mastectomies, came back in after having a lumpectomy on the outside. And that was the decision was made before this data was presented. And, I saw her last week and I, thought to myself, wow, if I had seen her before she'd actually gone to surgery, I might've said to her, you don't need to do this.
What was her mutation?
ATM.
Yeah. No, it is interesting. And, it just depends, for very young women, some people don't want to keep doing screening and worrying.
Yeah. I mean, the decision is still that is very personalized for sure.
I saw one woman who gets panic attacks and can't do MRIs. and has a BRCA2 mutation, but ER positive disease, it's really interesting because in that situation, it's really a big question, and the older you get at the first age of having breast cancer, the lower your risk is of having lots of breast cancer, right?
Yes, yes. And I didn't, for the sake of time, I didn't show that data, but they did actually focus on a population of patients that were over 65, where with those, with particularly PALB2, ATM check 2, they saw no breast cancers. And, if you're over contralateral breast cancers, I mean, not no, but 3 in the entire population. So for sure, women who are diagnosed at an older age, over 65, even it becomes, a law of diminishing returns with, BRCA2. It's kind of like if you've made it that long without developing you didn't get your first breast cancer till you're 65, it seems like you're in better shape.
Yes, absolutely. And you're less chance of having problems with your cancer. There's a question in there about surgery. Maybe you can answer on the Q&A
Sure.
box and we'll go on. So let's go on to Joe. And Joe, do you want to talk about this new hormone drug in the whole world of oral selective estrogen receptor downregulation?
Oh, I was thinking on the heels of that, we could talk about baby TAM.
Yeah, we can do that first. Absolutely. You want to talk about baby TAM?
Yeah, I feel like that was a nice segue. Okay, let me share my screen.
I wanted to try and get that other one in there, but we'll see. We can always do another session.
Okay.
No
Well,
worries.
Okay,
Go ahead.
I'll go fast. Okay, so this is an abstract really getting to the question of, can we use a lower dose of tamoxifen to prevent invasive breast cancer? And in this
Can
trial,
you put it into presentation mode.
oh, sorry, yeah.
That's okay.
Totally. Hold on one sec.
The bottom. I always use the bottom.
Okay. So this is a trial that enrolled high-risk patients and largely DCIS patients, but high-risk patients for developing recurrent breast cancer and wanting to ask the question, can a lower dose of tamoxifen be effective in preventing invasive breast cancer and breast events? As we know, there have been decades, whoops. It's weird. Okay, here we go. We have known for a long time, for decades, that tamoxifen can prevent breast cancer in high-risk populations. And that validated dose is 20 milligrams a day. We also know that there are a lot of side effects in our young women and older women who take tamoxifen at 20 milligrams a day. And because of that, the adherence and even the acceptance of taking it to prevent breast cancer, whether it's in somebody who has a genetic mutation or DCIS or LCIS or ADH, the uptake of tamoxifen prevention is very low. And so this trial asked the question, well, what about giving a lower dose of tamoxifen, 5 milligrams? And they randomized 500 patients to 5 milligrams of tamoxifen versus placebo, and enrolled patients who were at high risk of developing invasive breast cancer. So this included women who are under 75 with ADH, atypical ductal hyperplasia, LCIS, which is a pre-invasive lobular cancer, or ER positive or unknown DCIS, which is a pre-invasive ductal in situ carcinoma. They followed these patients for now a total of 10 years total. And back in 2018, I believe, they presented their initial data showing that they were able to, well, here's the patient population that they enrolled. Average age in the mid-50s, 40% were premenopausal. And you can see the breakdown of the kind of high-risk characteristics that they had. 67 to 66% of patients had DCIS, and most of these patients had radiation. And in 2018, they presented their 5-year follow-up. And at that time, they showed that with low-dose tamoxifen, they could reduce the number of recurrent breast cancers or recurrent DCIS by 50%. And they were able to reduce new cancers, meaning contralateral cancers, by 75%. And they also show that the 5 milligrams of tamoxifen was quite well tolerated. There was no significant increase in toxicity compared to placebo. And in fact, I think on average, they reported less than one additional hot flash with the 5 milligrams of tamoxifen compared to placebo. So after that, ASCO and our other oncology cooperative groups released guidelines, including baby TAM. So that's the nickname for 5 milligrams of tamoxifen for preventative therapy in high-risk lesions. And our National Comprehensive Network also recommended baby TAM as after DCIS if the patient was symptomatic or unwilling to take the full dose. This trial that was presented at San Antonio reported out on 10 years follow-up. And that's really important because we know with the original prevention data that the benefit really is continuous and can go out to 10, 15 plus years. And we wanted to make sure that that was indeed the case with just 5 milligrams of tamoxifen. These patients were followed annually with mammography and visits and sometimes telephone contact. And they wanted to look at the rate of invasive cancer or DCIS. And here are the high-level data. If you look at all breast events, meaning patients who had any breast cancer, DCIS, in those 10 years, if you look at these curves, they're separate. And the number of patients with recurrences was lower in the baby TAM group. So the red line represents those that got 5 milligrams of tamoxifen. So out of 500 patients, or around 250 in each arm, so 25 out of the 250 had a recurrence in the baby TAM group versus 41 out of 247 in the placebo arm. And that was significant. If you look on the left, this is looking at recurrences in the breast that had the original high-risk lesion. And you can see that there was a numerical difference here. So a difference of about 7 cases. And then if you look at the contralateral breast events, meaning new cancers, similar to what Michelle just presented, new cancers, these patients, the patients on baby TAM had a lower risk of a new contralateral breast cancer. So 16 out of 247 versus 6 out of 253. So that is a 75% reduction in contralateral breast cancer with 5 milligrams of tamoxifen. So the conclusions here were that the results seen at 5 years carried out to 10 years and looked very similar to what we have seen with the full dose tamoxifen. So that's very reassuring. These data is looking at just patients with DCIS. And again, the curves are separate, lower rates of recurrence in the baby TAM arm. And this table is very important, I think, because I want to know if in patients who took baby TAM, did the cancers that developed on baby TAM or after baby TAM, did they look different? Were they biologically different than those who developed recurrences without baby TAM? And the important one is looking here at the triple negative. There was no difference in the rates of triple negative cancers. And the reason I look at that is because in the original prevention studies, there was some question or hint that, if you took the tamoxifen, maybe if you were going to get a breast cancer, maybe you're at higher risk of getting a triple negative one because you were taking the tamoxifen. But in this study, small numbers for sure, but there was no difference in the tumors that arose after baby TAM compared to placebo. Importantly, it was very well tolerated. One of the things that we counsel patients on is the very small risk of developing endometrial cancer after 5 years or more of tamoxifen, and there really was no difference between baby TAM and placebo. Similarly, no difference in the risk of clot, which is another risk factor with full dose tamoxifen. And so the conclusions here were that 5 milligrams of tamoxifen for 3 years lowers recurrence of breast cancer in patients who have high-risk lesions that include DCIS, LCIS, ADH, And they saw this across all groups, ages, menopausal status. And to me, this really opens the door for discussions around prevention for patients, let's say, who may have, high risk genetic mutations, but those patients were not included in this trial. That's it.
So really interesting. And indeed, patients maybe who just, have high family history might want it or have, et cetera. But who would you recommend this for now?
I think right now, in patients for whom you are considering tamoxifen prevention for DCIS, LCIS, the people that were included in this trial, I think if the patient is not tolerating the full dose tamoxifen, baby tam dose is a very reasonable alternative. In my opinion, it's better to take some than none. And I think based on these data, I am more comfortable doing that. We now have long-term follow-up. I still prescribe the full dose tamoxifen. We have, many trials showing the benefit, and it's been validated in, multiple phase 3 trials. So that is still, I think, the standard. But I think 5 milligrams is a reasonable option in patients who have trouble with the full dose.
So you, just to go back on that, you wouldn't just use 5 milligrams routinely in a patient with DCIS who you're giving hormone therapy to?
Well, I don't see a lot of DCIS, but if I think it's reasonable, honestly, with these data, it's reasonable. It's 500 patients. I think you still need to, remember that's a much smaller than all of our prior trials for prevention.
So you're recommending some caution to be exercised, just depending on the risk of the patient and the situation. Yes,
Absolutely.
I think one thing that came up in the questions that Michelle kindly answered was somebody had asked whether or not, tamoxifen could be given to postmenopausal women. And of course, it was our standard for decades and decades. It's our first endocrine therapy for hormone receptor positive breast cancer. But this study did not occur in women with invasive breast cancer. So that would be yet another study. I mean, what we know is aromatase inhibitors are superior to tamoxifen for higher risk hormone receptor positive breast cancers. But this low dose tamoxifen was not tested in patients with invasive disease, only atypia and DCIS, as Joe went through in detail. I don't know if you had a patient who wasn't tolerating endocrine therapy, how low would you be willing to go, Joe, based on this data with invasive cancer?
Invasive breast cancer?
Mm-hmm.
So if it was a patient who really would say, I'm struggling and I can't take this, I would reduce the dose. I think it's better than nothing. I think there's a lot of supportive medications we can try to help patients tolerate our treatments, but sometimes, assuming that aromatase inhibitors is not the better treatment, but if we're talking about tamoxifen specifically, and they're having trouble at 20 milligrams, I am okay reducing it to 5. If the alternative was to take nothing.
Yes, I mean, I agree. And I think that, a lot of times what we do is go to 10 for a little while, help people adjust and then go back up to 20, just because that's the dose that was tested. But, in true medical form, there were never any studies looking at, many doses. It just 30 wasn't any better than 20 is all really only data we have. And, Michelle, is there, what are your thoughts on it? I know somebody's asking you what's tolerable or not, and how much would you push for full dose versus, a low sort of untested dose in a patient with invasive cancer?
Yeah, no, that's a really good question. I mean, I think, I used to be so, dogmatic that we didn't have patients would come in and, there are oncologists in the community that would, come to me for a second opinion, and they'd say, well, so-and-so told me that I could take 10 milligrams of tamoxifen a day. And I would sort of, be snotty about it and say that's ridiculous. But, with this data, I think that you can't, let, perfection be the enemy of good. If a patient has tried all of the supportive care strategies, with aromatase inhibitors, if it's body aches and joint pains, and we've tried duloxetine and they've tried, acupuncture and physical therapy and NSAIDs, and they just can't stay on the AI, and then they take tamoxifen and they have terrible hot flashes and they can't benefit from Effexor and gabapentin. We tried all the different symptom management strategies, and this is the only options, this or stop. I think that it makes sense to try a lower dose. I usually drop to 10 milligrams rather than 5 in an invasive population, and I've only done that a few times. But if I have someone who I really feel like they're going to benefit from endocrine therapy and it's this or quit, I usually find that patients do pretty well with 10. And there was a previous question I answered about how did they pick the 5. And, there were studies that were done looking at breast density that led up to this study, where they showed that they could give mice, 5 milligrams versus 20 milligrams, the Swedish group. They saw that the breast density decreased in a similar way with 5 versus 20. So if it was having that sort of same physiologic reducing breast density, the thought was maybe 5 is good enough in terms of preventing the recurrence or new primaries in breast cancer. So I dropped to 10, and everybody that I've dropped to 10 has been able to tolerate it. I mean, that's an N of 2 patients.
I think what you're hearing is that we are very pro endocrine therapy for hormone receptor positive disease, and we want people to be able to take it. And so if there are symptoms that are making it difficult for patients to continue and they don't want to, sometimes dropping the dose and trying to go back up or even switch to an AI eventually is one strategy. And what we want to do as oncologists is work with the patients to try and help get the therapy into them as much as possible in the best way possible. But we don't have any data on the efficacy of lower doses of tamoxifen for invasive disease as yet. So we don't want to start that way. But Lisa,
and I think it's also important to remember that trial compared to placebo. This is not a trial that compared 20 milligrams to 5 milligrams. And the reason that we are saying, there's some reassurance is because we're seeing benefit that looks similar to, what was shown previously with the full dose, but we actually have not compared 5 milligrams to 20 minutes. That trial just can't be done. To do prevention trials now would take way too long with too many patients. It's hard. We need these surrogate markers.
Nobody actually pays for those studies, so you have to.
Right, but maybe mammographic density. Like we need to start using these surrogate markers to help us answer these questions, because otherwise it just takes too long and too intensive and resource.
So one question that comes up sometimes, Lisa, with radiation is, we have data now in women over the age of 65 who have small hormone receptor positive cancers that you could forego radiation and give 5 years of endocrine therapy. How do you deal with the sort of adherence issue in your discussions with patients?
I think you bring up a really good point, which is that it's hard to know if someone's going to be able to remain on those treatments. So we really have a discussion with each patient. And we think of radiation as an insurance policy, and we know we can deliver it safely and we can customize the treatment, including offering partial breast to a lot of patients. So if there is concern that they're not going to be able to stay on it, then we can go ahead and offer the radiation up front. Because if you take the hormone therapy and you're not able to stay on it, we actually can't bring in the radiation years out. Radiation is something we can bring in shortly after the surgery.
Right. So it is an interesting question when you're thinking about tolerance of endocrine therapy and balancing with radiation in women who have small hormone receptor positive cancers in older age group. So let's go on, Lisa, maybe we'll have you want to talk a little bit about oligometastatic disease.
Yes. Let me try.
You have to define that for everybody, of course, as you know.
Okay. Let me see if I can make it bigger. All right, can you see the slides okay?
Yep.
Okay, great. I wanted to talk about ablative radiation in breast cancer. This was a topic of one of the educational sessions at San Antonio. And ablative essentially means high dose, typically directed at a metastatic site or a site of spread. And typically, once cancer has spread outside the breast or the nearby lymph nodes, the main treatment is actually going to be drug-based therapy, whether that's hormone therapy or chemotherapy. And that's because we want something that's going to go throughout the whole body. We will really only bring in local treatments like surgery or this ablative radiation when someone is having pain or other symptoms. But there is a question, could it still be useful to bring in local treatments if the cancer has not spread to many metastatic sites? And that's what this term oligometastatic means. The cancer has spread to a few distant sites. Typically, that number is 3 or less. The upper limit of that number is constantly moving higher as new trials come out, but it's a limited number of sites. And this figure here shows that the systemic therapies are a part of treatment for all these patients. But we can think about bringing in local therapies when the cancer is diagnosed as oligometastatic in the very beginning, or if a patient has a small number of metastatic sites of recurrence, that's oligorecurrence, oops, sorry about that, or if it progresses in a small number of sites. So someone might be on a systemic therapy, maybe there's 10 or more sites of spread, but most of them are under control and just a few are growing. That would be oligoprogression. And then the other end of the spectrum would be someone who has many metastatic sites. We could still think about bringing in radiation for sites that are painful or bleeding or causing other symptoms. And the rationale for thinking about bringing in local therapy like radiation metastatic breast cancer was tested in this study called SABCS. This was not a breast cancer specific study. Patients with all different types of cancer that had spread to a limited number of sites. In this study, they defined oligometastatic as 5 or fewer. Those patients were randomized to get the local treatment or to not get it. And what the authors found was that there was actually a large survival benefit when local treatment was added. One thing to consider is that this was overall a small study. It makes us, of course, want to investigate this issue further, but it doesn't specifically ask the question in breast cancer. It doesn't ask the question in other specific cancers either. And we know that each cancer has a very different course and different biology. And so that's what motivated this next study that was presented. It's called NRG BR002. This was a breast cancer specific study. Patients with breast cancer that had spread to a limited number of sites, in this study it was defined as 4 or fewer, were randomly assigned to get the local treatment to all the sites or to not. And if they did need palliation, they could get palliation, but they did not have the aggressive treatment. I want to point out that most of these patients had hormone positive, HER2 negative disease. And that trial was designed to have an interim analysis before it went on to the next phase. And because there was no benefit seen with the local therapy, it actually closed and it didn't move on to the next phase. Now, I'm presenting this study, not to kind of focus on the negative, but just to show that this is one small study. Doesn't mean that we can't think about bringing in local treatments for particular cases, and it really focused mostly on specific subtype of breast cancer, and we think maybe there could be a benefit in certain cases. So there's definitely a need for more studies, but this was a disappointing result. And there was another study I was going to present, but maybe I'll skip it for now, just in the interest of time. And I'll just go to the conclusions. So we know that radiation is still helpful for pain. Patients with metastatic breast cancer that's causing symptoms, we can definitely bring in radiation. The trial I presented doesn't provide support for bringing in radiation to all sites of metastases that aren't symptomatic, but it's just one study. And so we do need to support trials asking this question in specific settings. We know not all breast cancer is the same, so there's really a need to focus on specific biologies.
Yeah, I think that's so interesting. And I'll bring up a question for the group here, because, the idea here is that if you're in the unfortunate situation where you walk in with metastatic disease, to a few different sites, like maybe a single bone site or a lymph node and a bone, or 2 bone sites, et cetera, that maybe if you gave treatment that controls the disease and then you zap the areas where the cancer was, that you could somehow improve survival and improve the disease control. And of course, this study didn't show it, but my concerns about that study, I mean, it was really a lot of work for them. It was a small study relatively, and they included patients with all different kinds of cancer biology, where you had to hold the chemo, for example, for triple negative breast cancer when you were doing radiation, and patients actually did worse by taking that approach. And HER2 positive disease is quite different than hormone receptor positive disease. And then they included people who had, I think, 5 different sites. And so it was really, if you thought about just one site, maybe you would get a different answer. And I still have used occasionally this approach in patients who have very, very limited sites of disease when they first come in. Joe, your thoughts on this?
Yeah, I think there are conflicting data, as Dr. Singer mentioned. And so I think it's very case by case. I have also referred patients for this with limited disease, oftentimes bone-only oligometastatic disease. And, I think we should look at different endpoints of what is clinically meaningful. Progression-free survival is one of them, and that tends to be, along with overall survival, the gold standard for what is, effective. But I think there are other things like time to switching therapy, or time to starting chemotherapy if you are using endocrine therapy. And those are meaningful endpoints to patients and quality of life. So I think it's very case by case. And I certainly have referred patients, but the data are mixed.
Yeah, I think your point is so incredibly important that, just being able to have maybe stay on treatment for longer is not a bad thing. And, quality of life is really important. So on the other hand, I think in the advent of CDK4/6 inhibitors for hormone receptor positive disease, we also see really long disease control without doing that kind of radiation. So it is challenging. Other comments from the panel on this?
Yeah, I was going to say I have one of the questions that I would like to, that I think the trial that it would be great to design, are those patients on the CDK4/6 inhibitors long-term or other biological therapies where patient has 1 or 2 sites of progression in bone. I do tend to send them over because the patients are like, oh, if I just, zap that one, I can stay on this therapy. And I think it'd be great to sort of have a biomarker if there was a way to know that, and whether it would be cell-free DNA or something else that could predict, okay, is it better to just, zap those 1 or 2 or 3 and keep them on the same therapy? Or are we going to be, the very next scan, the patient's going to have 5 bone mets or 10 bone mets, and we would have been better off switching them. So I wonder if a trial like that is being designed. It certainly would be answering an important question.
Yeah, I agree. And also, do you think that patients with HER2 positive disease are different? I mean, I think one of the questions is, if you have great disease control, do you really need to radiate those extra sites? That's another question.
Well, yeah, and that's another point too. I try to mention to patients because, people are very enthusiastic about getting PET scans. And sometimes, too much information is not helpful, because you'll see an area where there's an increase in metabolic activity in the bone with no CT correlate, or a spot where there was, a previous bone met where now the metabolic activity is increased and the radiology report says, progression of disease. The patient reads progression of disease. And I said, if you didn't have good insurance and you could only get a CT scan, we'd be none the wiser, So I feel like, that this is, an argument that maybe too much information might cause us to be more reactionary and do more than we need to do.
Yeah. Definitely the case. And I think that has made some questions about using PET only for evaluation without, really understanding what's going on with the disease. We don't have a lot of time left, and I'm hoping we'll come back to you with more updates from San Antonio next month. But or I guess in a few weeks past next month. Joe has an interesting presentation about a novel endocrine therapy. There's been a whole field of oral selective estrogen receptor downregulators, and those who've ever gotten Faslodex or fulvestrant know that it's injection in the butt, it's painful, and you have to come in once a month for it. And there's been a lot of interest in these oral agents, but they've been dogged by toxicity until quite recently, where we have a number of oral SERDs that look quite effective. And Saya has one trial to talk about. There's another drug we're looking forward to see if it gets approved this next month in February, called elacestrant. But these drugs also may be more effective in patients who have some underlying resistance to hormone therapy. And one way we've looked at that is with estrogen receptor mutations. But there's a new class of drugs that has a lot of interest, and it's a fascinating mechanism that I think we now understand better than we did maybe a year ago. And we'll be opening a trial here with one of these agents. So I thought maybe Joe in the last 3 minutes could briefly show that data, just to say, a little bit about how it works and how we're going to study this.
Yeah, okay, I'll do speedy version.
And we'll have lots more to talk about when we meet again, because I think there's so many other things to talk about, CDK4/6 inhibitors, early stage disease, the Saya presentation on another drug, another AKT inhibitor. There's just a lot that was discussed at the meeting that is really exciting, the right kind of chemo for early stage triple negative breast cancer. And so I knew we'd run out of time, but we've had some really great discussions.
I don't know why I'm having so many AV issues today.
It happens.
Where is my presentation view? Gosh.
Now I can't see your presentation view.
Can you see my slides?
Yes, they're just scrolling for some reason. I'm not sure. You can do it the way it is now.
Okay, yeah, sorry. I don't know what is going on with my stuff. Okay, so ARV-471, and this is a new oral, what we call SERD, estrogen receptor degrader. And as Hope was saying, this is an oral version of a drug that has a similar mechanism to fulvestrant, which is also called Faslodex, which is used in the metastatic setting, often in the second line setting after resistance to an aromatase inhibitor. And the reason this drug is novel is that it's targeting degradation in a different way than all the other SERDs, estrogen receptor degraders. It binds both the estrogen receptor as well as this protein called E3 ligase. And when it does that, it brings this the estrogen receptor directly to something called ubiquitin, which is central to the degradation process through a protein called proteasome. So it's a complicated mechanism, but it's signaling the cell to degrade the estrogen receptor more directly through this ubiquitin and proteasome pathway, whereas the other estrogen receptor degraders kind of do it more through a generic degradation pathway. And there are many SERDs in development, as Hope was saying, and it kind of follows this theme of we are all trying to find more tolerable hormonal therapies, because we all know that aromatase inhibitors, as well as tamoxifen, aren't the easiest to tolerate for many patients. This drug, ARV-471, has already gone through phase 1 safety testing, and this trial studied 2 different doses, 200 milligrams of 500 milligrams. And the real purpose is to just look at what is the activity in a population of metastatic patients who have very resistant disease. So these are patients who had, for the most part, multiple hormonal therapies in the past. They all had a CDK4/6 inhibitor, and most had fulvestrant, and many had chemotherapy. Here is a summary of the patients, and I'll just say highlight that in terms of median number of prior regimens, so median 4 lines of treatment for their breast cancer, 3 of them were in the metastatic setting. I'll also highlight that 57.7% had a ESR1 mutation. This is an acquired mutation that is very common in breast cancer in tumors that have been exposed to hormonal therapy, and they evolve to acquire this mutation that makes them resistant often to aromatase inhibitors. And as I said, all of them had prior CDK4/6 inhibitors. All of them had prior hormonal therapy. 80% had prior fulvestrant, and the majority had chemotherapy. Okay, so toxicity is equally important to report here as efficacy. And one of the things I wanted to highlight is if you look at these last 3 rows, or the last, arthralgia and hot flash, these are common side effects with AIs and tamoxifen. And if you look at, grade 2, 3, and 4, let's just go to the far column under total, you can see there were no reports of grade 2, 3, 4, meaning sort of more serious, more significant joint aches, joint stiffness, hot flashes. That is remarkable, given that it's a hormonal therapy that degrades estrogen receptor, because we know those are side effects that really, really plague patients with AIs and tamoxifen. So they looked at how effective is it, and they reported out on clinical benefit rate, which is a little bit unique in that they are combining the percentage of patients that respond with the percentage of patients that just have stable disease, which is also a meaningful endpoint, because remember, these are very resistant patients. And so just getting, finding a hormonal therapy that can keep the disease stable, even if it's not smaller, is a victory. So they reported that 38%, no matter what dose, was about 38% of patients had benefit, right? Either responding or stable. And if you look at the patients that had tumors that had this ESR1 mutation, so the very resistant tumors, the clinical benefit rate was 51%. So more than half of patients benefited. So remember, very resistant population, 50% of them having benefit. And then they looked to see, in the tumor tissue, did the tumor actually degrade the estrogen receptor? So did the drug actually do what it's supposed to do? And they found that about 70% degradation. So that's showing that the drug is hitting its target. And we've seen in other studies with fulvestrant that number is much lower. It's, up to 30–40%. So, this is supporting the fact that maybe we are degrading the estrogen receptor better than some of the other SERDs, but this remains to be seen in clinical trials. So I'll just stop there. I'll say that, this is one of many SERDs that are being developed in a resistant population that is very well tolerated. We are going to be studying this drug in the early stage setting as well. We're studying it in the neoadjuvant setting, where we're giving it to patients before surgery. And when we do it that way, we can look at how the tumor responds and looking at biomarkers of response that we often can't do once we've removed the tumor. So we're really excited about that. That hopefully will open in the next month or 2.
Yeah, this is really great. And I love our neoadjuvant approach that Joe is actually taking our leadership role on at our institution. And the cool thing about that is that because it's part of our I-SPY program, not only is she taking lead for us, but for the multiple centers that are part of the I-SPY network. So it allows us to give endocrine therapy for patients before surgery have bigger tumors where chemotherapy is not going to make the tumor shrink much. And, looking at these more targeted agents and novel approaches is really, really key, because that's the only way we're going to move forward in treating these cancers in a better way for early stage cancer. For the metastatic setting, we have the trial opening in the next few months with this drug combined with CDK4/6 inhibitors, and also another oral SERD, elacestrant, which we hope to be approved in February. We'll hear from the FDA soon, also in combination with different targeted agents. So we'll have more options for our patients in the metastatic setting, which is really great. So I think that this presentation we really wanted to highlight because of all of those reasons, and really looking forward in the neoadjuvant setting, as well as having more options for our patients in the metastatic setting. So, you can make a big difference. I have one patient who went on ARV-471 alone, and another, a place where it just happened to have a slot open. but she had already been on a chemotherapy drug, an antibody drug conjugate, and had liver disease and lung, and actually is still on in 6 months. So, we can do these kinds of treatments, and some patients will really benefit a lot just having access to a clinical trial drug. So with that, I think that one of the questions was, are lobular patients included in the neoadjuvant trial, I think is what was meant. And yes, lobular cancer patients play a big role in your study, right, Joe? The neoadjuvant trial. So we appreciate, Kelly says in our Q&A, thank you for this fantastic Bay Area Breast Cancer Forum. Hope we can do this live and in person before too much time passes. And of course, we want to see people again. I think we also really appreciate that having this available on Zoom has made it accessible to so many more patients. And that's really due to the tremendous effort of Melody Gawliu, who also has advertised this and created a whole listserv and done an amazing job. I want to thank Michelle. I'm using everybody's first names. It's kind of funny. There's been this whole thing on Twitter about how when doctors talk to other doctors, that they refer to women by their first names and men by Dr. So-and-so, but I call everybody by their first name. So anyway, and so, these people are really make our program what it is, a remarkable place with incredibly caring and smart doctors who really think about this data, know it well, and provide excellent care, and are also doing a huge job in putting the new therapies into action in clinical trials in the smartest way. So thanks to Michelle, to Joe, to Saya, and Lisa for participating, and to Melody for making this happen, and to all of you for listening, and we'll see you soon.